Well, good morning, everyone. Can you hear me okay? Excellent. And thank you for that nice and very comprehensive introduction. That's much appreciated. You forget what you do over the course of your career. It's a pleasure to be here. I think I've been to Springfield once in my career at CDC, so this makes it a second. Still have not been to the Lincoln Memorial, and hope I can get over there at some point in the next day and a half or so. So thank you for inviting us, for inviting me, and for inviting CDC to today's session. And I think the focus, of course, on Public Health 3.0 is at the National Dialogue. So it's wonderful to see this action occurring here at this level, and it's certainly across the state and within your local jurisdictions. So thank you, Mr. Karoff, in terms of your opening remarks about change. I think just coincidentally, I was in my room this morning working on other activities, not so much preparing for this activity because it's something I look forward to and have done my preparation. But I ran across the video, Who Moved My Cheese? You're all familiar with that? It was this clever, just a version of it that was more cartoon-like with music, and it was very clever. And it talked about three principles, and really, just to refresh your memory, I'm going completely off script. The first was you need to when we're talking about change, of course, we're all afraid because change implies loss. Change does imply loss, but it also can imply gain. And I think as human beings, we tend to, this is the psychologist coming out, we tend to focus on the loss over the gain, and we're afraid. Fear is a natural reaction to change. And so the three tips that they really try to, I think, convey in this short video is, one, be smelling your cheese. It gets old. And at some point you need to know that your cheese is really old and it's time to move on. And so let's put this in context. I think some of the things we're doing in public health probably are getting a little stinky. And it's time for us to, maybe think about things differently or move into a different way of operating in order to be successful in continuing carrying out our mission. The second is read the writing on the wall. I think the writing's been on the wall for a good 5 to 10 years now. Certainly I can go back to some of the early reports from the IOM on the future of public health. I think that was around 2012, 2013, 2014. The writing was on the wall then. And then the third, of course, is be fearless in your exploration, which is a theme you brought up as well. So I just wanted to tie that together very nicely, because this is about exploration. I think as we talk about modernizing public health and aligning ourselves more directly with the changes that are occurring in the healthcare system, this is a great opportunity for us to be exploring and fearlessly exploring. If you don't know what you're doing, it's okay. Many of us don't know how to do fearless exploration, but that doesn't mean we can't try. And I think one of the beauties of this kind of a forum, and especially a forum focused on workforce, is how do we develop those skills within our own workforce to do that fearless exploration. And I'm going to speak to some of that and some of the strategies today that you as public health leaders and administrators and or program operators are very much, I think, aligned to and should be looking at in our future as we see our cheese move about. So I mentioned already the national trends in health system transformation. This is critical work that's occurring and evolving practically daily. But the good news is there's a lot being accomplished, and we're starting to see lessons learned across the country. So that's one of the advantages we have at CDC, is that we're not just looking at one jurisdiction. We can see the bigger picture from a national perspective. So certainly the work that CMMI and CMS have been initiating, if you recall HICPIA, and then the SIMS Awards, if that sounds familiar, and most recently the Accountable Health Communities. This is a great opportunity where the money is. First of all, if you want to look for some cheese, there's some money there, and a lot of it. Of course, public health isn't always at that table, and it's critical in each one of these rounds of payment reform and new ways in which we do service delivery and connecting the community to the expertise and services that are needed. Public health has to be at the table, if not leading and helping strategize for where to go to improve the health of the communities. So those innovative care and service delivery models are part of that. I know that the most recent round of Accountable Health Communities funding, and I'm not sure if there are any specific, they're at the local level, which is different from what we did in the SIMS work or what they've done in the SIMS work, but at the local level at least, and I'm not sure if they're here in Illinois, We're learning a lot about where public health can actually add value and not necessarily play the role of strategist, but be a strategist at the table. So that's the message you're going to hear me talk about, and you're probably going to hear very much about public health being the lead strategist. I think we will be a strategist among many strategists because every partnership that we enter into has a strategist in mind, and they're looking out for their organization as well as the greater good. And so I'm excited about the AHC work because it really is about connecting the healthcare sector, better connecting them to the social services and community services that are needed. And who does the best job at connecting at the local level? We do. It's something that we do naturally. It's part of how we get business done. We are by nature collaborators, connectors. This is what public health is known for. Not to mention, we bring an incredible expertise in data, and certainly the work we do around community health assessment, needs assessment, add value instantly to any partnership. And I'll speak to that in just a moment. The demographic changes clearly are important for us to all track. I don't know so much about the demographics in Illinois and certainly in this area, but certainly if you look across the country, we are becoming far more diverse, speaking multiple languages now, not just English, not just Spanish, and yet most of our messaging is in those two primary languages. And depending on the size of our jurisdiction and pockets of communities, they may be completely overlooked or missed because of just the language barriers, not to mention some of the cultural practices. So it really behooves public health to start looking beyond our traditional silos of epidemiology and surveillance and laboratory sciences. Those are critical and will always be very important, but to expand our role to look at those community or external factors, those are environmental, social factors that can really put populations at risk, which includes things like the social determinants of health, which I'll speak to and you'll be hearing about over the next 2 days. But more importantly, about how we can get to address what we see are some of the most striking health disparities across our country, simply because of where you live or who you are. And then I'm going to mention now in the next slide some of the expanding and evolving public health duties and responsibilities. I say this with kind of some enthusiasm, but I know there's a lot of consternation with this as well. Having been in the field of public health now for close to 25 years, I have watched and seen it grow from a very traditional set of public health services to embracing public health emergency preparedness and response, and embracing it very effectively and very well, bringing us into a systems approach for how we address and respond to crises, whether they be driven by health or diseases or by man-made or natural disasters. And so I think what's beautiful about Public Health 3.0 is it challenges us to go boldly where we have not been before. And now we're going to be expanding potentially as public health practitioners and professionals into areas of housing, food safety, education, I would say even transportation, economic development, community development. These are areas that exist, but we're not necessarily connected completely with them, and it's an area where we will need to go boldly and do our fearless exploration. Certainly there's new and emerging public health topics. I've listed a few here. Health equity isn't new, but certainly it's more pressing now than ever before, and so it's more of a considered evolving topic. Those determinants of health, I just read an article recently about the importance of multi-sector collaboration from a 2002 article trying to address the social determinants of health. It's not new, but it is getting a lot of attention, and so when something is getting a lot of attention and there's interest and money around it, we have to act. It behooves us to act. What is new, of course, is the opioids epidemic. It is the epidemic of our time, and it is something that our CDC director, Dr. Redfield, is very interested and, of course, very serious about addressing. I'm not here to talk about CDC, but you should also know he wants to, and he set forward some very clear priorities for our agency. And to share those quickly with you, it's not on my slide, but certainly addressing the opioid epidemic, and not necessarily from a downstream perspective, but from an upstream perspective. So what are those social determinants of health? What is prevention in this area? This is new territory for us, and something that I think is already happening in many communities across the country, but something that I think as we go forward, he really wants to move the needle and make progress, so keep that in mind. He also wants to end AIDS, period. And this is something, and hepatitis C, not on my slide set, but this is something where he truly believes that we have the technical packages already in place to achieve this goal. It's about how we implement. So he really is going to be pushing the agency in terms of implementation science to better understand the best ways to address those issues. Of course, emergency preparedness and response, a high priority for him and for this administration, and that will continue. And I think, if I recall, there was one more, immunization rates. And this again gets to the underserved communities and our racial and disparities associated with our immunization rates, and how can we bring those up. So all of this to say, you're going to be hearing more about that at the state level, more about that probably at the local level, and that on top of all that we're talking about today is overwhelming. And so we do, in addition to considering all these changes in scope, and then the workforce competencies that are required to make us efficient and effective in that area, we still need to address what's fundamental to public health. And I will speak to that as one of our strategies as a health strategist, to really help to define what is core to public health. We get lost in the sauce if we aren't able to say this is who we are and what we're about, but we also play in this other arena. Certainly work size reduction and succession planning continue to be one of the biggest challenges in public health from a national perspective. Budget limitations, constrained budgets drive a lot of that, and certainly attrition and layoffs are another big component of that. So we are forced to do more with less. We're losing key leadership and institutional knowledge across the country, and really thinking about upstream ways in which we can train and better develop a workforce for the future of public health, and to realize that vision of Public Health 3.0. There is, of course, growing demands for public health workforce in specific areas, in particular rural and urban areas. You would think urban areas would have plenty of resources, but you'd be surprised to know that they are sometimes well matched to what you would see in a rural area. And those reduced opportunities, that reduced workforce then reduces our opportunities, I think, currently and in the future, for improved integration with healthcare and social services, for improved delivery and service models and payment reforms. We won't realize that, we won't see that if we don't have the workforce well prepared and available to assist along the way. And that means more and new workforce skill sets. So this is not something probably you're unfamiliar with, but I think as we go forward, there needs to be that cross-cutting, multi-sector collaboration, leadership and strategic thinking and vision setting within what we do here in public health. And that is probably true in all sectors when we talk about this. It's not just public health. It's also transportation. It's also economic development. It's also urban planning. They have to have the same skill sets if we're ever going to be successful in achieving our overarching goal. Systems thinking is critical. Thank goodness for preparedness. I think it helped us to think beyond what we are traditionally used to doing in public health. And you know, one of the challenges with public health is we tend to talk to ourselves. This is something that we do every time. I mean, I'm a public health person speaking to a public health audience, and I'm grateful to be here. But and you're going to see, I think, on the portfolio of your agenda, you're going to have multiple perspectives. So this is a perspective you probably heard before when I'm up here talking. Not to say it's not valued and important, but it is also important to balance that out with other perspectives from other sectors. Informatics. Clearly, as we go forward, big data and data are critical for really understanding the needs of our communities. And what are the skill sets for data analysis, data analytics, and data visualization now that can really create messages that will resonate with new partnerships. And that includes the way in which new partners value the message. We really have to learn how they speak, what matters most to them. Is it return on investment? Certainly that's one of them. But it could also be things like, what's the value associated with this? Not so much the impact, what's the value of this particular effort? And that's a bit challenging because we have to measure value, which is not something I think anyone is good at, but I think we could do some work here and make a contribution. I'll briefly go over some national trends in public health workforce. If you're at all familiar with the NACCHO profile study, and I know you are, you've already seen this data. This is from the 26 profile study, and it's been published. I'm just throwing you some slides to put this in context. You're going to be hearing, I imagine, because I see Brian Castrucci on the agenda tomorrow, you'll be hearing a lot about Public Health Wins, which is a very exciting source of data on workforce, and far more, I think, comprehensive and different in many ways complements what we've done with our partnership with NACCHO. And what is most telling about this particular slide is that I think, I want to point out, I don't know how to use it, but I'm going to point out under all local health departments on the far right, the median number of FTEs, 15. That's across public health departments the size that serves less than 10,000 to serving over 1 million. And you look at the median because it's a better measure of central tendency than a mean in this case. 15 FTEs per health department. Completely can't be possible, I think, to achieve what we're here to achieve without addressing that gap. And then I'll also mention the less than 50,000 population served number, which is in the same ballpark, an average of 19 FTEs. And I don't know how that fits with the size of your local jurisdictions. I didn't see that data readily available, but is that within ballpark? Yes, okay. So you're right there in the middle with the rest of the country, but clearly this is a challenge for us going forward. This is, if you can read this, I'm not sure if you can read this. I liked this particular set of data primarily because it shows kind of those foundational workforce needs that are necessary, and I'm making that inference by looking at the small health departments to see what they have in terms of their workforce, what that composition means. Mostly registered nurses, office staff, leadership, and environmental. Clearly those are fundamental or they wouldn't exist at all levels depending on the size of the populations being served. But as you get larger and more complex populations and jurisdictions, then that's when you start to see the specialties come into play. So you'll see things like informatics, or I think public health emergency preparedness starts to kick in around metropolitan areas of about 50,000 or more. But that just gives you another kind of way to look at this. Your state probably houses many of the experts that you as locals need, and I'm assuming that those relationships with the state are there so that you can rely on them and in some sort of agreement, shared service agreement, as needed, because that's the way of the future. And the last slide, of course, is around national trends in terms of FTE loss and gains. I think it's kind of encouraging. It's just one data point from 2015, but it's a trend in the upward. Finally, we're seeing a trend in the upward direction. Ever since 2011 and the big recession and those extreme budget cuts and the loss of critical staff to public health, we have been losing staff pretty consistently all the way up to 2012 here, but that is now starting to show an uptick, which is a good sign. I don't know if it will continue, and what the current data on PH wins will show us, because it's more, I think, timely than what we have here to report. Certainly, layoffs and attrition are factors that aren't laid out here, and I know that's something that here in Illinois you all are facing as well. So just add that to the problem, and you do see the challenge, and we all are aware of the challenge. So let's talk about the Chief Health Strategist and what that means, and how you all, at least from the national perspective, how we're looking at it, and how you all are playing a critical role no matter what level of the governmental public health system and what role you play in public health. I think this is incredibly important because I've removed chief, and I know that doesn't, I'm sorry, I moved the chief, because it sounds like there's only one, and I mentioned that I think the reality is we're probably going to be one among many, and you within your organization may be one strategist among many, but clearly strategist is the key term, and health strategist is important to keep in mind. That health strategist nomenclature is what we're after. Who's chief doesn't matter so much, at least from my perspective, and I think from the perspective of some of the leadership at CDC. We play a lead role in many different ways. We may be the systems thinker, we may be that strategist. We may be the financial strategist. We may be the data strategist. There are going to be many strategists, or the financial strategist. There may be many ways in which we play a strategy role. But for now, chief strategist is fine. I think that's a nice framework for all of us to achieve. But keep in mind, when you're doing multi-sector collaboration, they have strategists too, and we're there to collaborate. So here are some of the characteristics of the chief health strategist. Certainly we see less of a focus on direct provision of care and more on policy. Policy is the prescription for prevention and for public health, and that's the level that public health should be working at, because we can actually affect the broader needs of the population. Convening, I've talked about that. We are the conveners. This is what we're known for. This is our bread and butter. We do represent diverse sectors, and we are well placed to work with diverse sectors. We've been doing this for decades. And I'm always surprised when people say, oh, community health assessment, do hospitals really work with health departments? I mean, local health departments have been working with local hospital systems for decades. And so I think that's something I continue to talk with at the national level, because they don't see it that way. And I think that's a misconception. There are emerging needs and new and emerging populations. Public health should have its finger on the pulse as a chief health strategist. And focusing upstream, we still have to get to a place where we can better understand what it means to be focusing upstream, how to explore some of that work, and what the partnerships are that are necessary to achieve work in progress in addressing the determinants of health. And of course, the issues around data. We don't need to have 2-year reporting delays. That unfortunately is a reality, but it is also time to move the cheese there, and it's already being moved. So in many cases, I think we need new skill sets, faster, more efficient, and more reliable sources of data collection. We have the technology. It's just now we're not able to adequately use that, and because we're used to doing things a certain way. Surveys are great, and they will continue to be a core component of what we do, but technology will be driving us to think differently, and our workforce will need skill sets to keep up with those changes. So I'm going to go through what I see are some of the key practices of the Chief Health Strategist. This was borrowed heavily from John Auerbach, if you know John Auerbach. For a short time, he was the director in OSTLTS and the Office for State, Tribal, Local, and Territorial Support. I didn't mention this, but we are now a proposed center. So we are now the Center for State, Tribal, Local, and Territorial Support, called OSTLTS. And if that's hard for you, we see stilts. Does that make sense? So we see you, and we're here to help represent you at the agency. And that's an important role that OSTLTS is playing and has played all along, to make sure that the voices of tribes, territories, local health departments, rural health departments, large health departments, and states are all being received and communicated to leadership at CDC and elsewhere. So I mentioned earlier that we need to better define what is core to public health. This particular slide you're very familiar with. We all know about the foundational public health capabilities and services, and I'm sure if I know Georgia Heiss, Dr. Heiss, she will probably be speaking about this. I don't know if Allison will, but certainly you're going to be hearing about the foundational public health services throughout the next 2 days. And it's important, although CDC doesn't completely embrace the concept, because we know we embrace the concept, but we don't embrace a particular model, because we know that this model is being implemented in various ways across the country. So Washington State is implementing it different from Oregon, who's implementing it different from potentially Kentucky. Ohio might actually have a different way. There's some work underway through the Public Health Accreditation FAB board that is actually looking and exploring how this work is expanding and developing in the field. But again, what is core, what is fundamental to what we do in public health? The second, explore and develop shared service models and strategies. This is one important way as a strategist in public health. Given our tight limitations with budget and workforce, this is critical. And you know about cross-jurisdictional sharing? Is that something you're familiar with? Somewhat? Okay. You're not a very active group, so you can raise your hand. It's okay. I may have one hand, but I'm raising it. So please do. So cross-jurisdictional sharing resources that you might find interesting, certainly our particular website, the OSTLTS website, the gateway for public health professionals that you may be familiar with, is a place where you can find more about cross-jurisdictional sharing, and you can see that link there on the slide set. I'm assuming the slide set will be shared with all of you. But I also want to point out the Center for Sharing Public Health Services, based in Kansas. This is an RWJ-funded activity. The tools and resources this particular group has developed are outstanding. And I want to just mention their latest, which is called COMPASS. COMPASS stands for Comprehensive Assistance for Shared Services, and it is an interactive tool that walks you through how to approach shared services. When we talk about shared services model, that could be within a jurisdiction. You may have a key epidemiologist that serves multiple jurisdictions. That is a type of shared service model. You may actually have a particular health department that is really good at a particular set of services that may provide those services to other local health departments in the region or in the jurisdiction. And you may have cross-state, cross-jurisdictional services with other states, neighboring states, who have a capacity or capability that you could benefit from, and vice versa. So keep that in mind. Look at this particular tool. It is quite interesting. I think the feedback we've received from the field, this is fairly new, is very positive, because it does highlight, I think, some of the lessons learned in ways that particularly the center has learned along the way. And it does include self-guided tours, which makes it really easy and kind of fun to do. So it's not a boring task, I promise. Practice number 3, explore and develop public health financing strategies. So you noticed I've broken these things down into particular types of strategists. And I don't mean to silo here. Brian Castrucci would kill me. I'm not about stratifying the workforce, okay? I'm just talking about, if you're an expert in a particular area, become the strategist in that area. And then expand your roles into some of the other strategy areas that you need. And this is really about how do we cobble together funding to address things like the social determinants of health, just to help enhance our workforce. And that's obviously, there are many opportunities for that are currently in place. Billing for services is one, and I know in the Chief Health Strategist framework, moving away from billing and services is something that is encouraged, because policy is where we're going to get more traction. That said, there are many local health departments and state health departments that still are in the business of billing, because it's a good source of revenue for them. That doesn't mean that we're saying don't do it. You should continue to do it if it's something that works well for you. But again, it's an excellent source of revenue. Health and wellness funds is another example, and there are a few of those that currently exist across the country. I think Massachusetts comes up as one of the examples, if you're not familiar with one. They've formed a health and wellness fund. Again, this is where philanthropy comes into play as a partnership. Social impact bonds, I'm not going to get into social impact bonds. There's a whole piece on the STILT website that I mentioned earlier that talks about social impact bonds as a financing source under public health law. So you can see that under our public health law services. Community health needs assessment and benefit, we all know what that is. It's unrealized. And I think that's important to mention, because I hear quite frequently, though we partner very closely with hospitals, oftentimes the decision about what those funds are actually going towards are being made inside the walls of the hospital. And public health and the community are oftentimes left out, even if we are doing the assessment in a collaborative way. So we have to overcome that barrier for us to realize the vision of Public Health 3.0. Braided and blended funding, also a really important area. It's happening, I know, at the local level in various states. Virginia comes to mind. I think there's some work in Louisiana as well. And there's some, if you go to the NASB website, you'll find some interesting articles there. I'm happy to share some of that if you're interested in this. California in particular is doing some interesting ways in which they're lumping state and local revenue in ways that you can actually use it for multiple purposes. And there's an accountability component to that that makes sense. So I think there is some work happening at the local and state level. The feds are a little more challenging. And for obvious reasons, because most of the funding streams are well placed, they're congressionally, they're line items that Congress agrees to, and they're very clear about us keeping those line items clean. But we are looking to ways in which we can explore. We're expecting in the future more discussion around block grants. There's a real kind of mixed reaction to that idea of those flexible funding dollars, because we may be losing money in the process. But maybe there's a balance. Maybe there's a way to strike a balance so that we have block grants that augment our categorically funded programs. We'll see. So keep an eye on that. Certainly community development sector, $2 billion a year goes towards community development. That sector is untapped, and the beauty, they don't know how to measure the health impacts of that work. Well, who does that work? We do. So I don't know if you're familiar with the community development sector, but this is a great place for us to be doing more exploration work and really tapping into not only those resources, but that effort, because they are about multi-sector and collaboration. And they're not looking, although health is a component of that economic and community development effort, it is not something they measure. And wouldn't that be nice to have an opportunity to be a part of that effort? And of course, the business sector. For the public health, this is one of those IOM reports I mentioned from a few years back, and if you're interested in learning more about financing and innovative ways to finance, that's a great resource. Practice number 4. How am I doing on time? I don't have a watch up here. Oh my gosh, okay. Before questions? Or am I out of questions too? Okay, I'll speed along, okay. So, this is about evidence-based practices. I'm going to be very brief. This could be very brief. Develop adopted strategies that promote health and wellness. You're familiar with those evidence-based strategies? If you're not, oh no, where did they go? Okay, here's some of them. 618, are you familiar with 618? These are 6 topic areas where we have 18 interventions that are actually able to deliver a health outcome within 4 years. So this is a great opportunity, especially for our appointed officials, to make a difference within their term by implementing these types of interventions. Another one is High Five. You're familiar with these. These are wonderful because they're really focusing on the social determinants of health, but follow the same format. They are really focusing on achieving results within 5 years, and that's why they're called High Five. So again, I'm not going to spend a lot of time here. I'd love to, but go to these resources. Our policy office at CDC was instrumental in developing these along with the communities. I'm going to go back to my practices. So that was what I meant by this idea of the quality of evidence and evidence-based practices. If you're innovating, please, please, please evaluate. So if you don't have an evidence base for what you're doing and the community is interested in doing something different, it's okay. But you have to be monitoring it about. You need data to understand what worked and what didn't. And this is where quality improvement, another one of our really important contributions, comes into play, because we want an environment where we can continuously improve. Data across sectors, I talked about this already at the very beginning. Big data is particular. Those surveillance systems, that common platform, the interoperability, the unrealized potential of electronic health records. Most hospitals have them. Public health needs access. So those are some of the things we're talking about when we talk about you as a strategist. Maybe you're the data strategist. I don't know. I'm not siloing people. It's just that, I think we all bring something to the table. Again, this is more about that building a more integrative system through collaboration. This is that multi-sector collaboration strategy, practice number 6, and this is about investing in our community. And if you can see on your right, the visual there that talks about ways in which the physical environment, the social environment, data, and how we can package these things in such a way that we can make a difference in addressing some of those determinants of health. Practice number 7, you want to collaborate with a broad array of partnerships, and you want to be doing that at multiple levels. So at the state level, at the community level, at the local level, at the regional level. Who are your local funders? Who are your local health systems? Who are the regional or state health systems that you should be working with? I wanted to mention, I didn't mention him. I do want to mention him because I was so impressed. Just a second. Forgive me. I think it was on my very side. Okay, Dr. J. Bott. Familiar with Dr. Bott? Yeah, you should be. I just learned about him. So he came to CDC last week to speak about his current work, but he also spoke very, very, very nicely about Healthy Chicago and about HEN, the Hospital Engagement Network, and the incredible work this strategist has made for the health of Illinois. And I just found his work to be very compelling. I don't know to what degree those legacy activities continue, but that's, when I think of a chief health strategist, that's who I think of. And so that doesn't mean he's the only one, but he's a good one to look to. All right. We know our public health system. We know about partnerships. We like to put ourselves in the center, but we're not always in the center of the Skittles diagram. Oftentimes we might be way over where police are, and that's okay. We're okay. We're fine not being the lead in everything. I think it's fine to be a contributor. That's what we do best. We just tend to be public health centric, and we need to move away from that, and this slide should reflect that. I should move us someplace else. I can make us a different color, but centered makes it sound like we run the rule. We rule everything, and we don't. We all know that. Key practices number 8, replace outdated organizational practices with state-of-the-art business accountability and financing systems. This is very clearly one of the pillars of Public Health 3.0 and one of the main reasons why we are about advancing public health accreditation. And as you know, CDC has been very supportive of this. We're thrilled to see so many jurisdictions in Illinois be accredited. We're going to continue to push that. You're going to hear probably about accreditation from Dr. Heiss, I imagine. But this is about really shoring up our back-end services so that we have high-quality services and that we can actually be more accountable and work more efficiently, and in developing that continuous quality improvement culture that's needed, especially in times of great change. So yes, FAB accreditation is important. I'm not going to spend a lot of time on the role of accreditation. You've heard this, but just know that version 1.5 and soon to be 2.0, not to mention re-accreditation, is really emphasizing some of these characteristics of Public Health 3.0. So you'll see things like a heavier emphasis on health equity, informatics, public health healthcare integration, multi-sector collaboration, that chief health strategist, leadership, partnerships, it'll all be in there. It's all going to help drive us to be better able to meet the needs and changes that we're facing. And my last slide, the call to action. So we know about Public Health 3.0. I can speak from a federal perspective because this was something under the former administration. We don't refer to it so much as Public Health 3.0 at the national level, but it's still very much alive at the national level. We talk about the concepts, we talk about the themes. Dr. DeSalvo was instrumental in her role as Assistant Secretary for Health. And with her work and the work of local communities, because she spent many days working, traveling across the country to develop this framework. It's a beautiful framework, and those themes are what we're about here today. And thank you for this opportunity to share what we're doing at the national level and what we're hearing.